deprivation aspects and their effect on, you know, metabolism and sleep. So thank you so much.
No problem. Thank you. My pleasure.
All right. And now we'll let our next team start up. Thanks.
Hi, good morning. I have the distinct pleasure of presenting Dr. Elain Boland, who will be presenting assessment and treatment of circadian rhythm disorders. Dr. Boland, I did my residency and fellowship at Temple, so I see that, yeah, she received her PhD in clinical psychology from Temple University, after which Dr. Boland completed a 3-year advanced fellowship in mental illness and treatment at the Philadelphia Veteran Affairs Mental Illness Research, Education, and Clinical Center, where she's now a principal investigator. She also has a dual appointment as clinical associate in the Department of Psychiatry at the School of Medicine at the University of Pennsylvania. Dr. Boland's research has focused on the intersection of sleep disturbances, circadian rhythms, and reward function in mood disorders, and she has authored multiple publications. She's currently in her 3rd year of a VA Career Development Award, investigating reward processing impairments in the depression insomnia comorbidity. She also has a strong service with working, being a member on committees in the Sleep Research Society and the American Academy of Sleep Medicine. In addition to her service and research work, Dr. Boland is committed to clinical work. She provides individual and group cognitive behavioral therapy for insomnia, focusing on veterans with chronic pain condition, and provides consultation on difficult cases to other CBTI providers. She's also a clinical supervisor for the Philadelphia VA Sleep Center Practicum Program and has delivered multiple national webinars on CBTI. So please, Dr. Boland, whenever you're ready.
Wonderful. Thank you so much for everyone for having me here today. I'm excited to talk to you about the assessment and treatment of circadian rhythm disorders. I have no conflicts of interest to disclose. Here's the accreditation statement that I'm sure you're all very familiar with at this point in the conference. So just as an overview, what I'm going to talk about today is first a bit of a primer, so just to get some general understanding about what circadian rhythms are and how they're entrained or sort of synchronized with the environment. We'll then move into an overview of what the intrinsic or sort of biologically derived circadian rhythm sleep-wake disorders are, what some of the symptoms are, what you might see in sleep centers. And then we'll move into, well, how do we assess and treat these disorders? So talk about some of the tools of the trade and what some of the recommendations are for treating these disorders. We'll move into a little portion where we don't talk about necessarily the intrinsic circadian rhythm disturbances, but more environmentally mediated ones, so shift work disorder and jet lag, just because some of those conditions are also common in sleep centers. And then finally, just touch a little bit on some areas for future research where there's gaps in our understanding and where things need to go. All right, so biological rhythms, these are really just representing natural cycles of change of your body's chemicals or functions. And there's different types of biological rhythms. There's ultradian rhythms. These are rhythms that cycle multiple times within a 24-hour period. One example would be your heartbeat. Ideally, our hearts are beating multiple times throughout the day and complete that cycle multiple times. A circadian rhythm, however, is going to be about 24 hours. Our circadian rhythms, I say about because it's not exactly 24 hours, actually a little bit longer. And finally, you've probably heard of infradian rhythms. These are cycles of processes that take more than 24 hours. So if you want to consider maybe the female menstrual cycle, for example, takes 28 days. And chronobiology as a science is just the study of these timings of biological functions. And circadian rhythms are ubiquitous. They're everywhere in the human system. So there are going to be circadian fluctuations in your body temperature, in your blood pressure, in secretion of melatonin. Melatonin is going to come up a lot in this presentation today. This is a hormone that is very tightly connected to sleep-wake regulation. You're going to have circadian rhythms of alertness. So when we talk about a circadian sleep-wake cycle, we're often referring to this alertness rhythm that cycles within a 24-hour day. And just to give you some terms that are going to pop up here and there when we talk about treatment and assessment, you might hear the word acrophase. This is going to represent the timing of the peak of a particular circadian rhythm. The mesor, you might have heard, this is the central tendency or kind of the mean of that rhythm. And nadir is going to be the opposite of acrophase. It's going to be the timing of that trough or the low point of the circadian rhythm. The amplitude of a rhythm, you think about it as kind of the robustness or the strength of that rhythm. It's just going to be the difference between the acrophase and that mesor, or the nadir and that mesor. So a high amplitude rhythm is going to be something where the signals are very strong, both at high and low points. A less strong, lower amplitude rhythm, it's just going to be harder to detect those timing cues. And then finally, period length is important. Period length is just representing how long it takes for a full cycle. So the period of a circadian cycle is about 24.5 hours. So here I'm just depicting just a graph of the circadian rhythm of your core body temperature. The reason we pick body temperature here is it does tend to track with the sleep-wake cycle rhythm. So we see here that your body temperature is lowest in the morning, the early morning hours, usually before waking, and then it rises throughout the day, not completely linearly. There is a little bit of a dip there. That dip in core body temperature in the middle of the day or early afternoon is something that tracks with your alertness. So if you have felt sleepiness or some tiredness in the afternoon, it could be that you had a lot of spaghetti for lunch, but it could also be that you're experiencing some of the dips in alertness that kind of track with that body temperature. But then we're going to reach our peak body temperature at the end of the day. And what tends to happen is that body temperature is going to start to decrease, right, and begin that cycle again, and that's when we start to see typically the onset of sleep. But circadian rhythms are not the only things that moderate or kind of regulate rather the sleep-wake cycle. So it's a very important component, but it works in conjunction with another process which we call the homeostatic sleep drive. You may have heard of this referred to as sleep load, sleep propensity, sleep pressure, but it has more of a behavioral component. And so I don't know if you can see my cursor here. So this bottom part here is your circadian rhythm, where we see that this alertness rhythm is getting stronger, I should say, as the day goes on, and then waning during the evening hours. But we see an opponent process, or this sort of opposite, going here with sleep load or your sleep drive. So if you think about just waking up in the morning after a nice, refreshing 7 to 9 hours of sleep, the drive to sleep at that point is going to be pretty low. They're not going to have a high pressure to go to sleep because you just slept. But as the day goes on, that pressure or that sleep load is going to increase to where you're going to get a pretty strong signal to go to sleep because of the strength of that sleep drive. And what we see is that kind of gets synchronized here with that circadian rhythm, such that when sleep starts, right around here, you're getting these two signals where the sleep drive is really high and the circadian rhythm, or that alertness signal, is starting to decrease. So what we can see is that if there's something going on with this circadian system, when this is not sort of timing at the appropriate time, that no matter the sleep load or the drive that's accumulated at that point, we could still potentially have difficulty falling asleep if, for example, the alertness is way too high over here or way too low over here. So we're going to talk a little bit more about how that synchronization happens in a few slides. And then it's important too to talk about this term Zeitgeber. I apologize to any natural German speakers for my pronunciation, but it's a German word for time giver, and it really just represents these external time cues in the environment that are going to regulate and synchronize these internal circadian rhythms. There are a lot of things in the environment that can give us timing information, but the strongest Zeitgeber, the strongest cue from the environment is going to be that light-dark cycle. So prior to, industrialization, before we had artificial light, it was going to be really easy for us to just follow those light patterns, and that would be really the rising and setting of the sun was going to be key for keeping that circadian system in sync. And it's really important from a melatonin perspective. So melatonin, which I said before, is a very potent timing cue for sleep. Melatonin is suppressed whenever there is light present. So the presence or absence of light is very important in communicating to the body whether or not to produce or release that melatonin. And what we see here is just sort of a depiction kind of simplistically of what's going on. We get light information from the environment. There are photoreceptors in the periphery of our eyes that are kind of hardwired to a part of our brain called the suprachiasmatic nucleus, so the SCN for short. And so that part of the brain takes all of that light information and sort of outputs it to these physiological or behavioral responses, and that sort of connection is what keeps a lot of the functioning going from a circadian perspective. So light is going to be a really potent communicator. It's going to be connected to melatonin. So these are things that are going to come up when we talk about assessment and treatment. One thing that you might already be thinking about is, well, okay, you said light was going to be really important before industrialization, and so we followed the rising and setting of the sun. What about now where we have light all over the place? So it's important to understand that there are different spectrums of light. So the sun is going to give full spectrum, but there's a specific wavelength called blue light that is particularly important when we think about circadian regulation. It's almost like that part of our brain is particularly responsive to the blue wavelength of light. And what is unfortunate about this day and age is that all of our electronics purely emit that blue light. So we can think about another way that from a circadian perspective, we're getting a little bit of a misfire there because we're getting these light inputs potentially at all hours of the day. So iPhones, iPads, smartphones in general, computer screens, they all emit this blue light. So again, we will talk about that in a few slides when we talk about assessment and treatment. And then the final thing that I think is important for people to understand is this difference between circadian and Zeitgeber time. So circadian time is really just this standard unit. It's based on this endogenous free running period, meaning your circadian period of 24.5 hours without any information from the environment. And so circadian time 0 would be the onset of activity in diurnal or sort of day active organisms. And that's a little difficult to conceptualize, I think, sometimes from a human perspective, because you're like, well, what is activity? How are we defining that? It might be easier to think about from mice models, right? So if you've been familiar with any mouse studies, they pretty much go from asleep like straight into the wheel, right? There's no dilly-dallying. They're much more exercise motivated in confinement than humans are. So circadian time 0 in a mouse model would be, when did they get on that wheel after they were done sleeping? Zeitgeber time is going to be a little different. Zeitgeber time is going to be based on the period of the Zeitgeber. And so if we're thinking about a 24-hour light-dark cycle, Zeitgeber time 0 is going to be lights on, right? At what time did the on period of that Zeitgeber cycle start? And we're going to talk about both of those, again, when we come up to assessment and treatment. All right, so now that we're all armchair chronobiologists, let's talk about what are these intrinsic circadian rhythm disorders? So what happens when rhythms are not doing what they're supposed to do? So one of the first ones is advanced sleep or advanced sleep-wake phase disorder. And what this is an advanced or earlier timing of sleep. We see sleep offset or awakenings about 2 or more hours prior to that individual's desired wake time. In this disorder, we want to see symptoms present for at least 3 months. And what can get kind of confusing about this disorder is it may present in a sleep clinic as an early morning awakening, terminal insomnia kind of presentation. We tend to see the same kind of excessive sleepiness during the day as we might see with someone with that specific kind of insomnia. But what might be a really important indicator is that the sleep quality in someone who has advanced sleep-wake phase disorder is generally going to be good if they're able to keep that advanced schedule. So if they're able to fall asleep very early in the evening, wake up very early in the morning, and keep their lives that way, the quality of their sleep during that sleep window is going to be pretty good. Advanced sleep-wake phase disorder is not super prevalent. It's only about 1 out of every 2,500 patients that we might see in a sleep clinic. More people will come in reporting an advanced sleep phase than not necessarily advanced sleep-wake phase disorder. And when we're thinking about what's the difference between an advanced phase and disorder, we really want to be thinking about impairment and distress. Right, so if somebody has an advanced phase, but it's not impacting their lives in any way, we're not going to necessarily put a disorder diagnosis on that. There are some genetic links. There's no specific advanced sleep phase gene, but about 1 in 475 individuals will have a familial version or have family members that also have this condition. And we do tend to see this to be more prevalent in older adults. There is a longitudinal sort of developmental shift in circadian timing that happens across the lifespan. Individuals as they age do tend to start to have kind of a more earlier phase, which makes sense for why we might see this disorder more pervasive in older adults. So on the opposite end of the spectrum, just that you can have an advanced phase, you can also have a delayed phase. So this is a delayed sleep onset relative to the individual's desired bedtime. And again, this might present in a sleep clinic as initial insomnia. So someone who reports real significant difficulty falling asleep at night. They also are going to have really difficult times waking at the required time due to their later phase. So their alarms are going to be going off potentially when their biology is telling them to be in some of the deeper stages of sleep. And again, one of the differentiating factors that we have here is that, again, when the delayed schedule is able to be maintained, when someone can go to bed very late, wake up very, very late, we're not going to see poor sleep quality. They're actually going to be sleeping pretty well. And again, for this disorder, we want to see these symptoms present for at least 3 months. It's a little bit more prevalent than advanced sleep-wake phase disorder. It's depending on the study, between 0.5 to 16% of individuals. Again, more frequent in adolescents and young adults. From that developmental perspective that we just talked about, we do tend to see more delays in phase in this population. Some studies say this may be due in some way to a longer intrinsic circadian period. So individuals with delayed sleep phase disorder might just have a longer than 24.5 hour circadian period. In individuals with delayed sleep phase disorder, there have been observed delays in dim light melatonin onset, as well as core body temperature that tend to track with that delayed phase. But the etiology is not 100% understood. There's still a lot of black box areas. There's some evidence that in addition to a circadian component, these individuals have a diminished sleep drive. So that homeostatic curve that I showed you before doesn't build the way that it should. There are some studies showing that this might be due to a hypersensitivity to evening light. So, the light exposure that they're getting in the evening is having an effect on delaying their rhythm. And then also, like advanced sleep phase, there are some studies that point to genetic variants. But if people are interested, there's a really good article that I've boxed out here on the etiology of delayed sleep phase disorder as a reference if you're interested in more information. All right, so non-24-hour sleep-wake rhythm disorder. This is when an individual completely fails to entrain or to synchronize with that 24-hour light-dark cycle. What we see is usually a progressive delay. Sometimes this can occur as a progressive advance of the sleep-wake pattern. The individual is going to have a lot of daytime sleepiness, a lot of daytime or nighttime rather insomnia, and this might make a lot of sense. This tends to happen most often in individuals who are blind, right? So they don't have the receptors in their eyes functioning properly. They're not getting that light information. That SCN is not able to keep everything regulated. So they're not entrained or synchronized with their environment and their period free runs. It still can occur, however, in individuals who have full vision. It's just the etiology there is less known. So just to show you what I mean here about free running. So in an entrained period here, this is someone who is sleeping on a regular schedule using cues from the environment. If we took that individual out, put them in what we call constant conditions, or if we just imagine that this is a actogram of someone who has free running or non-24-hour rhythm disorder, what we see is that there is this progressive delay. So as the days go by, sleep time gets later and later and later, and it just is going to follow this this rhythm. Eventually, it's going to be at the same time. It's just going to be a big loop. Again, so in terms of etiology in the blind, this is just due to a loss of synchronization to the 24-hour day. They're not getting that light information. Like I said, we really don't know as much what's going on in individuals that have full vision. There are some studies that suggest that maybe this is due to a kind of an internal, continually delaying circadian rhythm. Some studies point to potentially a longer melatonin period, but again, there's still a lot we don't know about what really causes this to happen in those that have full vision. And then the last of the intrinsic disorders is irregular sleep-wake rhythm disorder. So here we're just seeing a lack of any kind of circadian pattern to sleep-wake. What these individuals typically present with is a lot of hypersomnolence or sleepiness during the day, a lot of insomnia at night. There's no, sleep can look very chunky, sleeping in snatches, a lot of fragmentation in the sleep. And this type of circadian rhythm disorder is really much more common in those that have neurodevelopmental or neurodegenerative disorders. Age alone is not a risk factor, but age-related neurological and psychiatric disorders are. So things like Alzheimer's disease, for example. And there is some evidence that this disorder is due in large part to a central degeneration of the neurons in the SCN. But it can be compounded by some of the lifestyle factors that tend to get associated in individuals who have these disorders. If they're living in institutionalized environments, for example, there often is not a very strong social rhythm or daytime cues that can potentially strengthen or entrain that rhythm. So the disorder gets compounded potentially by lifestyle. All right, so we know the disorders. How do we assess for them? How do we make the difference between these circadian disorders and other types of insomnia or sleep disorders that we might see in a sleep center? So there's been a lot of talk already about chronotype and circadian tendencies. So I'm really not going to go into this too much. You all know the difference between an owl and a lark. What I will say is that the distribution of these circadian tendencies kind of follows a bit of a normal curve, meaning that we don't have a ton of people that are going to have real extreme eveningness or extreme morningness. Most of us are in the middle here. But in terms of how you even assess for owlness or larkness, there are two questionnaires that are often used. There's the morningness eveningness questionnaire that has about 19 questions. It asks about not just when you sleep and when you wake, but also when do you feel most alert, when do you feel most tired, when do you feel most energized. And it gives you this continuum of scores where lower scores are going to mean you're more of an evening person, higher scores are going to be you're more of a morning individual, so kind of a continuum there. There's also the Munich chronotype questionnaire that you can give. This has 6 questions, so a little lower burden in terms of assessment, but it assesses the habitual sleep timing on work days. It also accounts for free days. So an individual's sleep on the weekend, for example, when they're not working could be very different than when they're on a tighter schedule. And the outcome is not a linear score, but rather just what's the mid-sleep point on these free days that are corrected for, or on regular days corrected for oversleep. So it gives you a bit of an estimate of where their midpoint is as opposed to where they fall on a morningness or eveningness spectrum. Actigraphy is a really important tool of the trade. It's a wrist-worn device. I think many of you are familiar with actigraphy. It's just an accelerometer. It's measuring movement, but it's really the software that can delineate between sleep and wake periods. You can wear it for several days. People are so used to wearing Fitbits and Apple Watches at this point that the burden of wearing an actigraph is much smaller these days, I think, than what it might have been in other times. The issue with actigraphy is that there can be what we call masking effects. So meaning that it's not going to necessarily show us a true circadian rhythm if we're only looking at activity. Basically, the major masking effect is going to be behavior. So just because someone is going to sleep at a certain time, it's not because they want to necessarily go to bed at that time. Things like exercise, if that's too close to bedtime, can increase body temperature, make it difficult to fall asleep. Certainly work schedules, school schedules, activities, things like that can mask some of these circadian effects. And we'll see here too, I mean, it can be difficult really to see any kind of circadian pattern. This looks pretty entrained. There's some deviations in sleep length, potentially due to bouts of sleep during the day. We wouldn't necessarily call that an irregular sleep-wake pattern just because someone's, experiencing some sleep during the day. What we see here, maybe this is more of a evidence of a continually delaying rhythm, right? But we wouldn't want this to be the only piece of evidence that we have. It can definitely be good corroborating evidence, but we want to, understand that certain things like activities can mask these effects, and we want to get a pretty good detailed interview about what the individual does on a day-to-day basis. You can also collect sleep diaries if actigraphy is not available and you really just have to rely heavily on self-report. You may be used to the types of sleep diaries that you use in other sleep treatments that ask the timing of certain points in sleep. So, when you fell asleep, when did you wake up, how long were you awake in the middle of the night? This is more of a visual sleep diary where you can get almost a sense of the patterns in the way that you would from an actigram. The individual just sort of shades some of these areas where they're sleeping versus where they're awake, and you can kind of eyeball a little bit what the pattern might be. I will say for all of the intrinsic circadian disorders that you're going to want to have actigraphy or sleep diaries before confirming a diagnosis. So you want 7 days of this information for all except non-24. Non-24, you're going to want 14 days. Excuse me, to get a sense of what that continually delaying rhythm is. Okay, there are also other assessment approaches that are a little more burdensome, but potentially more accurate. So dim light melatonin onset, you heard about in the last presentation. It's arguably the most reliable circadian marker, and it's going to be representing the timing of the SCN, which controls melatonin release. So typically what happens is melatonin levels begin to rise about 2 to 3 hours before habitual sleep onset. And so what dim light melatonin onset assays will do is measure multiply, so usually in about 30-minute increments over about 6 to 8 hours, we'll measure the concentrations of melatonin in the blood or saliva. So this is something that's often done in a hospital setting. There are sort of take-home or ambulatory measures of DILMO that do place a lot of burden on the individual to be able to adhere strictly to the measurement. And again, this has to be in dim light, so light suppresses melatonin. So if all the lights are on when you're doing this test, it's not going to work. So again, it's a very accurate assessment of circadian timing, but not necessarily feasible in outpatient settings. There's also measurements, again, of core body temperature. So body temperature is a pretty robust measure of circadian rhythm. But again, this is going to have to be a 24-hour measurement. We can't just hold a laser to our foreheads and see what time or what our temperature is in the morning versus the evening. Temperature can be monitored either rectally, or sometimes there are pills that can be swallowed that will kind of collect 24-hour internal body temperature before being passed. So again, not something that is easy to use in an outpatient setting. Okay, so how do we actually treat these disorders once we've assessed for them and found some evidence that maybe there is something intrinsically going on with the rhythm? So when I talk about some of these treatment methods, I'm going to give a lot of different points about the treatments, but I'm also, wherever possible, give you the American Academy of Sleep Medicine's clinical practice guideline recommendations. So this is a great article if you're interested in more in-depth information about what the AASM recommends. So whenever possible, we're going to just refer to what those specific recommendations are. But you'll see a pattern across all of these treatment options, that there's a lot of room or need for your own clinical judgment. So one of the treatment options is actually using oral melatonin. So Melatonin, you probably see it in your grocery store all the time. It's sold over the counter. It's not regulated. It's considered a supplement. So according to AASM, there's weak evidence for use of melatonin in delayed sleep-wake phase disorder, both in adults and children, in non-24-hour disorder in those that are blind, and in children and adolescents that have irregular sleep-wake rhythm disorder. And when I say weak evidence, I don't mean that the evidence is like just okay. It just basically means that there's a lower level or lower degree of clinical certainty. So they were using the GRADE criteria. There's a lower level of clinical certainty, but the majority of patients, if they were given information about the pros and cons of this type of treatment, would decide to use it. So it's kind of those two pieces of information together. There's weak evidence against using melatonin for irregular sleep-wake rhythm disorder in the elderly who have dementia. There's some contraindications with melatonin that we're going to talk about in just a second that are particularly important for or applicable to older individuals that have dementia. And then there's no specific recommendation for use of melatonin in advanced sleep-wake phase disorder or non-24-hour. And no recommendation doesn't mean that they recommend you don't use it. It just means that they don't have enough evidence from the literature to make something specifically recommendation level. So again, you're going to need to implore some clinical judgment, your knowledge about the patient, their circumstances, etc. So melatonin, how do we decide how much to give? And in melatonin, it's actually the timing of melatonin that may be more important than the dose. So in typical medications administration, you consider kind of a dose response curve where the increased dose is usually commensurate with an increased effect. What we're going to be referring to for melatonin is what we call a phase response curve. So the phase response curve, this is the relationship between the timing of a Zeitgeber, in this case melatonin, and the resulting change in phase, right? Let me show you here. So this is, sort of walk you through it here. So down here, this is the circadian time, but it's going to be easier if we think about this in terms of Zeitgeber time, which has been superimposed here. So this is going to be the period where the organism is awake. This is going to be when they're asleep. This spot right here, this middle point, is just kind of the mid-phase point. And so anything above this is going to suggest an advance or an earlier timing of the rhythm. Anything beneath is going to be a delay in the rhythm. So there's two things I want you to sort of take away from here. First is that light is a much stronger Zeitgeber than melatonin, so it's going to have a much bigger effect on that advance or delay. But also there are points in administration where the effect of the delay, of the advance or the delay, is going to be stronger relative to other times. So for melatonin here, if you want the largest advance, right, if you want to use melatonin to advance the rhythm, not super easy to do. You want this person to take melatonin when they're asleep. Probably not gonna happen. But when we're using melatonin to treat delayed phase, meaning that we want to have their rhythm advance, we want them to be taking it earlier in the evening. Same thing with light here. Light is going to advance the rhythm. So if someone is administering early morning, oh, this is the opposite actually, now that I'm looking at this properly. Light at night is going to delay. So this is an opposite. I apologize. I was saying this incorrectly in terms of when the timing was. This is just wonky. We have to think of this as asleep and this is as wake. But light administered before bed is going to delay the rhythm. So if we're thinking about blue light exposure that people have at night from electronics, that's going to have a bigger delay effect than if they were getting that light exposure in the morning. So the timing of these, both melatonin and light, is going to be important in administration. Okay. The thing too to understand is that the optimal dose of melatonin is going to remain, we really don't know what that is. There hasn't been enough information. I think, to my knowledge, I don't know of phase response curves that have been published for doses above 5 milligrams, although sometimes people do administer melatonin in doses up to 10. The timing, as I said, is going to be more important than dose. So if we're talking about improving delays, again, we want to have afternoon about or early evening administration of melatonin. A morning dose of melatonin is going to delay the rhythm. But the studies vary in terms of timing. So there's no prescribed clock time really necessarily for individuals for when this should be administered. Typically, I'll say anecdotally, what we often do in the sleep center where I am is about 2 hours before the desired bedtime. But again, there's a lot of recommendations. The AASM doesn't have a specific timing recommendation. And I think it's also important to recognize that melatonin is not without side effects, even though it's sold so liberally. It really should be administered with a physician monitoring or consenting if you're a non-prescriber like myself. So I'm a clinical psychologist. I don't have prescriber privileges. I do feel very lucky to be able to work in a sleep center where there's a lot of physicians around that can prescribe, and I can work with them to do so. But it's, you just want to be cautious if you're not a prescriber in how you recommend this. It's generally safe. There really are not a lot of contraindications like serious effects. There are some adverse effects. So some people have reported headaches, sleepiness, hypotension, some GI upset. There can be an increase in depressive symptoms that has been reported. That's the main reason why we, for the weak evidence against using this in irregular sleep-wake phase disorder where there's already potentially an underlying propensity for those symptoms. And there have been case reports that urge caution in those that are using certain blood thinners like warfarin or those with epilepsy. All right, bright light therapy. So this, if you remember from that phase response curve, is going to be a much stronger zygamber than melatonin. So the timing of bright light can be a very good way of trying to advance or delay a rhythm. So according to the AASM, there's weak evidence for the use of bright light in advanced sleep-wake phase disorder and irregular sleep-wake for the elderly with dementia. There's no recommendation for delayed sleep phase or non-24-hour, but again, no recommendation doesn't mean don't use it. It just means that you have to rely on your clinical judgment here. There's a lot of options these days in terms of what bright light therapy is available. So you can choose full spectrum bright light or specifically blue enhanced, because like I said, that blue wavelength is going to be particularly important for entrainment. You really want light exposure to be on the periphery of the eyes, so not staring directly in that. We don't want to burn any pupils or corneas. You can have light boxes, so there are, I think have been some advances that they look a little less bulky than they might have in the old days. But there also have been some advancements in wearable technology where an individual can wear something kind of like glasses that have the light, either at the bottom of the rim or the top that can emit that light to the periphery of the eye. So what that might be an advantage for someone is that they can continue on with their morning routine. So they're not necessarily having to sit stationary in the morning when they may not really have a lot of time in the morning already. Again, I think everything has side effects. It's important to understand who you're suggesting, who the person is that you're recommending this to, and understand what their conditions are. You definitely want to be careful in someone that already has a certain type of eye condition, like macular degeneration, if they have any kind of photosensitivity. There are certain skin conditions, particularly, for example, those seen in lupus, where bright light therapy can actually worsen some of those skin conditions. Individuals who take medications that make them more photosensitive. The biggest issue would be in those that have a history of bipolar disorder. You really want to monitor use there. There have been some reports that bright light can kind of help someone convert into a manic episode. So depending on, that individual's history and if they're under close monitoring at that point, it can be used. It's not explicitly contraindicated. It can be associated with headaches in those that are susceptible to migraines. Some individuals might have that with bright light therapy, some eye strain, nausea. The reports overall suggest that these side effects usually tend to be short-lived if they are experienced. So overall, a pretty benign treatment, but you want to make sure that you understand the person's underlying conditions. Oop. Okay, so then timing of bright light, again, it's going to differ depending on whether you're trying to delay or advance the rhythm. Sorry, I'm getting a delay in this slide advancement here. There we go. So delayed sleep phase, if you're trying to have someone's rhythm advance, then you want them to have early morning light exposure. So if someone is sleeping till 1 or 2 in the afternoon and you want to start advancing that rhythm, you want to have them use it between 2 to 3 hours before the natural wake time. This is based on a review, but there's no specific AASM recommendation for this. For advanced sleep phase, we want the opposite. We want that light exposure to be in the early evening hours to try to delay onset. And it's really, if you just think about the fact that light suppresses melatonin, it can help make conceptual sense that you want that light exposure to be in the evening or at night when we would normally see that melatonin onset. In individuals with non-24 hours, this would be in-sighted individuals. We wouldn't really see any effect in those who are unable to actually perceive the light. So you want to essentially prescribe a wake time and then administer the bright light shortly after. For irregular sleep-wake phase disorder, there have been recommendations for light about 3,000 to 5,000 watts. That's getting at the strength of the light. 2 hours each morning for 4 weeks is one recommendation. That's not an AASM specific recommendation, but just based on clinical reviews and studies in the literature. There is also the option for what we call dark therapy. It sounds kind of dystopian, but really it's just playing on this idea that if you can strategically administer light, perhaps you can strategically remove light so that anything that's getting in the way of the rhythm can potentially no longer be an obstacle. So there's no evidence for or against this based on the AASM recommendations, but it does have some face validity, especially if you have somebody who has, for example, a delayed sleep phase, and they're reporting a lot of ambient light or excessive light use in the evening. So dark therapy would really just be minimizing light exposure at the wrong time of day. It can help increase melatonin production if light is suppressing it. So this is where you would want to have somebody really employ as many of those kind of night shift options on their tablets or phones. So what it'll often do is put a filter so that the blue light is filtered out, kind of turns everything orange. This can help reduce the amount of light exposure that they're getting to the SCN at the wrong time. I believe there are certain glasses that might filter out blue light that can potentially be helpful. So again, no evidence for or against this, but it's a fairly benign therapy that, depending on the person's history, could be a helpful therapeutic option. And there are other therapies, but these do not get any kind of specific recommendation for their use according to the AASM. So there is the option for prescribed sleep-wake scheduling. So it has been referred to as a specific type of chronotherapy, just called chronotherapy. Essentially what happens is the person about every 3 days will sort of perpetually delay their sleep onset. About 2 hours. And so they're going to bed later and later in chunks of time until they get to the point where they're at their ideal bedtime, and then they try to sustain that bedtime using typical sleep hygiene environmental cues. So it really takes somebody that has the ability to navigate their schedule, because at some point in that procedure, someone's going to be going to bed at 3 p.m., they're going to be going to bed at 12 p.m. The person has to be really dedicated and have the ability and flexibility with their schedule to do that. So you can maybe see why it's not commonly prescribed. There is the option of timed physical activity or exercise. A lot of physical activity can be connected to the core body temperature, and so if you want somebody to try to be able to go to sleep later, perhaps having them do exercise or working out later in order to influence that body temperature as a way of delaying sleep. And then another option is wakefulness promoting medication. So individuals who are really just struggling with the amount of sleepiness that they have at the wrong time can potentially work with physicians on certain types of medications that could promote wakefulness. So again, no evidence for or against any of these options via the AASM. There's really a lack of kind of cohesive evidence for or against any of these. Where there is strong evidence against, however, is the use of sleep-promoting medications in the elderly individuals that have dementia, specifically those that have irregular sleep-wake phase disorder, but I think in general, older individuals that have sleep concerns, we really want to be cautious against sleep-promoting medications. There's fall risks and all of these other things that, as sleep professionals, you're aware of with older individuals and sleep medications. So those are the kind of intrinsic sleep disorder recommendations. I want to spend a little bit of time talking about shift work because we are going to, or you probably have seen a lot of individuals that come into your place of business that have symptoms connected to shift work. We're living in an increasingly 24-hour culture where there are many jobs that have to kind of occur around the clock. So the incidence of shift work sleep disorder is probably increasing, and it really just affects those who work non-traditional shifts, so those who work overnight. And for some people, it's a really big difficulty adjusting to a daytime sleep schedule. And so shift work sleep disorder is a scenario where we kind of have two goals. One is to improve the sleep when they're actually able to sleep, but we also have to be conscious of their alertness levels when they're working, because many are working in shifts where there needs to be a lot of alertness, or there's high risk for danger, and accidents can be life-threatening. So really are working with these two mutual goals. Shift work sleep as a disorder is associated with age. There are studies that show that older individuals tend to be sort of less resilient to these shifts and have a harder time in training or regulating their sleep when they have to work in opposition to their rhythm. So what are some sort of self-management options? So minimizing sunlight when driving home. So if you have to be sleeping during the day, many are often driving home right when that sun's coming up, and that can be particularly difficult when, from a sleep perspective, you're getting light right before sleep onset. So either using sunglasses safely, if you can, to try to minimize that light. People who take public transportation, trying to block the light as much as possible in the commute home. A big thing that we work on for treating shift work in the clinic is trying to have individuals maintain some kind of consistency on their weekends or their off days. And this is a totally understandable scenario, but individuals who work late shifts want to get their lives back on the days that they're not working those shifts. And so what happens is you have not just a reverse shift all the time, but you have this flip-flop between day and night sleep, which can just really wreak havoc on that circadian system. So trying to work with individuals to see, is there some sort of happy medium we can reach on those off days to try to keep as much consistency as possible. And that often involves getting some household buy-in, so getting individuals, families, to really pay attention to the noise level and other types of disturbances when the person is trying to get some sleep. This came up in an earlier presentation today about sleep in the military. So planned naps for safety and alertness are going to be particularly important. So before leaving for work, if the sleep had not been good during the day, sleeping on breaks, things that would be helpful for helping that person stay alert and safe when they are working. And then just trying to make sure that if you have to work nights, that you're able to avoid, to the best of your ability, a long commute. Less of an issue if the commute is via public transportation and you're not driving, but we really want to make sure that the individual is able to mitigate some of that drowsy driving that could be associated with shift work. In terms of clinical treatment approaches, so there is a lot in the research about improved sleepiness with wake-promoting medications such as modafinil, so having a consultation with the physician about a way to keep alert during the day. And again, this is kind of fitting that double-pronged approach of focusing on work alertness versus just sleep during the day. There is a study showing that light therapy, so prior to the core body temperature minimum, so that has typically happening for most people at night, so that right before typical sleep onset on a normal diurnal schedule. So some light therapy or light exposure, perhaps at the beginning of the night shift, could be potentially helpful in shifting that rhythm. And then finally, we want to be aware of just how difficult it is to try to have to force yourself to sleep when your body really doesn't want to. And it's that sleep effort that is often very connected to insomnia. So if an individual who has been working shifts for quite some time has developed some cognitions and behaviors that are kind of connected to perpetuating an insomnia-like state, then potentially cognitive behavioral therapy for insomnia could be helpful as an adjunctive, try to help relieve some of the distress that's often associated with this kind of sleep effort that they've been putting in. Jet lag, it feels weird to talk about jet lag because I feel like nobody flies anymore. But in the old days when we actually could leap time zones, this would be a scenario where you wind up in a different time zone and your circadian system is just not caught up. What we do know is that this can be a syndrome that is much more severe in older adults, similar to what we saw with shift work, that there's just a lack of resiliency in that system in individuals as they get older. But what we don't talk about as much is not just the circadian shift itself, but what tends to go along with travel. Travel is not always stressful, but it quite often is. You know, there's a lot of deadlines trying to get to your gate, sleep loss from trying to get a flight that is not in alignment with your typical life, and then a lot of excessive caffeine use to try to prop yourself up. So a lot of the difficulty with jet lag can also be exacerbated by these other components. So if we're working with someone on, how do we avoid this if you're traveling for something, to give a talk or do something that requires you to be on point for work, how do we mitigate jet lag? Some of it might be just trying to see how we can mitigate some of these stressors and schedules prior to travel. And there has been some evidence that the same strategies we would use for other types of intrinsic circadian rhythm disorders might be helpful in a jet lag situation. So scheduling your sleep and leading up to the travel so that you're not having such an abrupt shift between your sleep pattern at home and what it will be when you're at your destination. And then using bright light and time melatonin in kind of the same fashion we've discussed before to try to help adjust your rhythm to your destination point. And then finally, where do we need to know? So I think a lot of the things that I said today indicated that there's either no recommendation or there's not enough work. And I think that speaks to the need for some more studies so that we have finer tuned recommendations. We can know more about what to do, when to do it. So we really, I think, need some larger, more rigorously controlled trials for circadian rhythm disorders, and we need to replicate them a little bit better. One thing that came up in that clinical guideline article is that not all of the studies were adhering to the International Classification of Sleep Disorders criteria, so we're not always seeing people that have for example, irregular sleep-wake disorder, but people who might have characteristics. So it might be important for these studies to really adhere to these criteria. We need to know more about the proper dosing of melatonin and bright light. So as you saw, the recommendations vary in terms of what time, and are we using a clock time, or are we using distance from ideal sleep time? So we need to know more about what the precise recommendation is, and also what's the minimum required treatment. How long do we need to be doing this, because we don't want to be administering something longer than we really need to. We need to know more about the environmental factors. This isn't always about circadian biology. There are environmental cues that could be sort of clouding the water, so to speak. And then I think really importantly, knowing more about the advantages or lack thereof of these wearable light technologies. If bright light being as strong as light vapor as it is, if there can be to make it more palatable and usable by the public, then that could be a real move forward in some of this treatment. So with that, I'll just say thank you. I don't know how we're doing on time, but if there are any questions on any of this, I'm happy to answer.
Thank you very much. I will tell you that this is a great ending to our conference. So I appreciate that. We're ending with like a great lecture. I will tell you that I was very intrigued by your background, and not directly spoken in this lecture, but could you comment on the effect of electronics, blue light, etc., on mental illness, on curtailing the sleep, and on circadian rhythm, and how has it been shown that since the advent of the iPhone, the smartphones, how has that affected mental illness?
So yeah, I think I can speak more about the mood disorder piece of mental illness, maybe, and anxiety, but I think what there's going to be a lot of differing findings in the literature. I can say from experience that we've had that it becomes a bit of a feedback loop, right? So we have individuals that might have higher levels of anxiety at night, might have feelings, if one is depressed, of isolation and disconnection, and that these devices are providing, either connection to other people, which is potentially serving that or speaking to that disconnection piece, or it's soothing anxiety in some way because it's serving as a distraction. But what's happening is when the distraction is coming from something that is potentially speaking to that part of the brain that's delaying the rhythm, what we have then is a sleep disorder that's going to potentially further or perpetuate some of those mental health symptoms. So, what we work on in CBTI, for example, a lot of the veterans that come in have a lot of depression symptoms, have a lot of anxiety at night or hypervigilance. And, when we're speaking to that blue light problem specifically, it's really just trying to help people detach from the source, but not the reason for using it, so trying to make sure, well, you love reading. Does it have to be on your tablet? Can you read a book? Or, you want to be able to be in touch with people. Let's talk about, writing letters. It's really nice to receive mail these days. Can you put those words down and when you're awake and sort of kind of get out of sort of delaying your rhythm unnecessarily. There are studies in the literature that show that eveningness is more associated with more severe depression symptomatology. So whether that's purely biological, I think that there probably is some sort of feedback with that as well, that there are activities that are happening later at night, perhaps because of the person's intrinsic biological rhythm, but then the light exposure that they're getting from the devices is just sort of compounding the effect. So I think as a broad mental health question, it's intriguing. And I think depending on what you read, you're going to get different answers. A lot of it's speculative about what the overall impact is, and a bit of a chicken and the egg question too about, is it a circadian issue that brings about some of the mental health issues or vice versa. But there's been a lot of burgeoning research that I think is really exciting, showing that circadian rhythms are not just tied to depression, but are really altered in things like OCD. There's been some new research showing that more severe OCD symptoms are associated with delayed phase. So I think we're going to find more, I hope, in the coming decades about how that is actually connected. I don't think it's just about the quality of sleep, though, that comes from it.
We have a lot of questions, so we're going to go with the first one. What have the case reports indicated for the use of melatonin and warfarin? Asked by Michelle Guzman.
I'm not familiar with the specific reports myself, other than just in general, there have been one or two that have caused some concern. So that is just part of how the AASM came to that recommendation, but I can look into what the specific case report is. I just know that there's been some contraindication. And again, with case reports and not, results from an RCT, we want to, be careful about over-interpreting that, but I think it's just worth mentioning.
We have another question. When you do behavioral light melatonin interventions, does the core body temperature shift, or is that unchangeable?
So
asked by Catherine Book.
Yeah, so there are some, so there's a literature about shifts in core body temperature, like particularly in shift work, like if you're using light therapy, and some have shown that the core body temperature rhythm advances or delays a little bit. What tends to come out more, though, is that there are changes in the amplitude, so the robustness. So it's not that we tend to see just sort of like a less robust circadian rhythm as opposed to the same strength of rhythm just delayed. So it's not the perfect treatment for shift work. It doesn't just help us completely reverse, but it can potentially lessen the intensity of that cue at the wrong time because it's blunted the amplitude a little bit.
So we have another question that says, in patients with delayed sleep phase, do you worry about the initiation of light therapy prior to a clear assessment of the timing of the sleep phase, with concern about the use of morning light before the core body temperature minimum?
Yeah, so I think that speaks to some of the questions in literature about, do we need to know exactly what their circadian timing is, or can we just go based on their behavior? I think I will say that assessment is very important. As a provider myself, I would never initiate any kind of chronotherapeutic intervention without having a real full assessment. And what that might mean is just I need at least a week or two of diaries to really see what's going on. That's not going to tell me what their core body temperature minimum is, but it's going to give me a little bit of an understanding of what their habitual sleep is like and help guide some of that light therapy. And, I think some of the recommendations we said before are about maybe 2 or 3 hours before habitual wake time. The biggest thing that I worry about with light therapy is making sure that this is not someone who has bipolar disorder that we just haven't properly assessed for, since we do tend to see more delayed phase in mood disorders, just really screening for that.
Yeah, the person asking the question makes a comment also that they find that patients in their experience routinely minimize the delay, and so they take 3 or 4 weeks of logs to be sure.
Yeah, and so 7 days should really be a minimum, right? And what can be difficult, the masking effects that we said that came up with actigraphy can come up in sleep diaries too. And if you really want to get a clear pattern of what's going on, multiple weeks when you're able to see their behavior on these free days and days when they have a pretty controlled schedule can really help you see whether there's a delay, as will their report on the quality of their sleep when they're not sort of confined to having to wake up at a certain time.
Dr. Elain makes a comment that I think very practical and useful. She says BTW Ubex makes cheap orange lens glasses that are approximately $12 and can be found on Amazon. BTW Ubex. I have a question, but it's kind of like a funny question in a way, but I get asked this all the time. So they always ask me, what brand of melatonin do you recommend? I have been asked that 100 times, I think. And what dose?
I wish I had an answer. It's an unregulated substance. So, I will say, and this is just my own, I'll classify this as opinion. This is not clinical advice, but I'm very wary of melatonin products in general. I mean, you'll find like melatonin in tea, they're putting it in everything as though it's this kind of like panacea for all things sleep related. And, at some doses, it can have kind of a hypnotic effect. So some people might be taking it just because it might make them sleepy, but it's like the Wild West in terms of, understanding what you're putting in your body. So, I never make recommendations for brands or anything, and some of that comes from being a non-prescriber, but I also I don't have any knowledge to back it up. So,
And I have to tell you that pediatricians are given this a lot. And a recent study was published with mice. So these are mice. This is not humans, where they gave super high dose of melatonin. They injected it in the abdomen, and they found that so this is not reproducible in humans or anything, but they found that these very high doses of melatonin in rats promoted early puberty. So it's kind of, and they're giving it a lot in kids. I mean, that doesn't mean that it will happen with like a 1 milligram in a child, but this has to be studied a little bit more.
So there was one study that looked at pediatric prepubescent individuals and compared Tanner stages. So they looked at, stages of pubertal development in kids that had been given melatonin versus those who were not given melatonin. And that study didn't find any differences in like delays or advances of pubertal status. So that's just one study, but I'm as wary as the next person about, stuff with children before we really understand the, effects on growth hormone and things like that. But nothing,
Yeah. I just got a lesson, like how the teenagers do the abbreviations. So I just got a lesson from Dr. Elain. When I said that the BTW Ubex, she just educated me that BTW means by the way. So the brand is actually Ubex. Okay. And one, I'm learning with my own kids. And last question before we finish, do you have experience with the Luminet blue light system? This question is asked by Mike Dubik.
I do not. I am not super familiar with a lot of commercial blue light or blocking blue light things. You know, our clinic is pretty traditional when it comes to, you know, use some light boxes or, you know, melatonin prescribed through the VA system. So I have not had too much interaction with those things. I apologize.
Well, no. We don't either. So I did learn my lesson, but for BTW.
If you take anything away from this presentation, I think that's a good thing.
That is worth the whole 2 days of the presentation. I want to thank you so much, Dr. Boland, and for coming and giving us this great lecture. And we hope to see you in person, maybe do a quick drive 2 hours to Baltimore next year for the conference. And I want to have John Brown, please, as our president, give any final comments.
Monty, we have to get Beth Kligerman with Elaine because they're friends and they've actually done work together. So I think we have some bait to put on the hook to take them out to lunch.
The floor is yours, Dr. Brown.
Folks, for the question regarding melatonin and warfarin, I checked with Dr. Google because he's a good friend of mine and a lot smarter than me. And so Dr. Google pointed out that there have been some case reports of prolongation of the INR for patients who are taking warfarin. And I think what I will share with you is something Dr. Dement pointed out in his book on sleep, which is that in the United States, melatonin is considered a food supplement that is not regulated by the FDA. Saying that, what I will point out is to say that, you know, a lot of times we don't think about herbal medications, or we may not think about food supplements sometimes in our history. And I think we learned a lesson from ginkgo biloba. We had several patients who came to the operating room who had some bleeding complications and found that they were associated with ginkgo biloba. So I think the message I would share is to say, look, when you are offering melatonin as a potential therapy, please take a look at the medication list, and please think about warfarin and maybe just share that concern about the possibility that there have been case reports of prolongation of PTINR with some bleeding concerns. So as you probably already noticed, my colleague Sushil Patel is here. Let me do this. Number one, thank you everyone for attending. I want to thank all the speakers for a fantastic job. I want to thank the technical crew for the amazing support that they provided, especially on the fly, to help deal with any issues and make this look, in my opinion, seamless. I want to thank the audience for their great questions. I want to thank the vendors for supporting this conference and helping us to provide a quality show at a reasonable price. And so the last statement, CME, one of the things, we will send an email. This will be done through the American Academy of Sleep Medicine. I promise you, you will be hearing from us by email. Before we go, I had been told yesterday about a statement that is called a technical draft on CPAP written by AHRQ, which is a division of Health and Human Services that does literature reviews and makes some commentaries and guidance. And so one of the things that was pointed out to me this morning by a colleague was that some of the statements regarding CPAP is based on what they consider the strength of the evidence to be low, and just say that they were less than impressed with what they believe are clinically relevant measures related to outcomes on CPAP. That was my initial impression of the few statements that I read. So I happened to reach out to Dr. Patel this morning, and he has informed me that he is actually involved in working with a group of people right now on a response with respect to that technical draft, which is under revision and review right now. Sushil, would you like to share with us any thoughts or comments?
Yeah, sure, John. Thanks for the introduction. Yeah, so I think just by way of background, much is not known in terms of the rationale for the request for this review. as John has mentioned, AHRQ is an agency of Health and Human Services that does these technical reviews. This was a formal request from CMS or Medicare to do this technical review. It's not clear exactly when the technical review was requested and, when, AHRQ finally decided to do it over the last 2 years. So the focus is really just looking at the effect of CPAP on quote-unquote long-term clinical outcomes. And if you know anything about these technical reviews, for example, there was one in 2019 looking at non-invasive ventilation and ventilation for COPD, for instance, and reviewing the evidence for that. When that happened, one of the consequences of it was to kick off a process within CMS, which has led to a discussion and relooking at the NCD and LCD for respiratory assist devices. And that's going through a process right now, which has actually been fairly positive, actually. In this case, we're not so sure this is a positive development based on the tone of the report. But it's by a group of authors that are unknown, but at an academic institution at this point, done on behalf of AHRQ, on behalf of CMS. And they basically ask two key clinical questions in this review. Question number one essentially was looking at the effectiveness of CPAP on quote-unquote long-term clinical outcomes. Within that question, they limited their review to look at studies that had clinical outcomes at greater than 6 months and 1 year. Specifically, they look at a number of different outcomes, particularly mortality, cardiovascular disease, as well as a non-cardiac outcomes like quality of life, anxiety, depression, and some other things as well. Absent from all of this, and probably the key point of consternation so far for most that have read the document, is that it doesn't acknowledge very well that, it's clear that at the very minimum, there's clear benefit that's been demonstrated for CPAP and OSA for the treatment of patient symptoms, particularly sleepiness in this case. And so that's caused a lot of concerns because it's really buried in, they do acknowledge it, but it's buried in the manuscript. And that's been probably the focus of most people's thinking of a response. The second key clinical question that they asked is really looking at the AHI and whether the AHI is a good measure and whether or not it's a surrogate for clinical outcomes. And in that space, there are very few studies, quite honestly, that have looked at this question. And so as a result, because the evidence base is rather thin, they concluded at this point in time, the AHI can't be looked at as a surrogate for these outcomes. There are some concerns from a methodology standpoint and what have you. All of the societies that are sleep related are aware at this point on the national level. So the Academy, ATS, Sleep Research Society, American Academy of Neurology, the World Sleep Society, the Respiratory Society, National Respiratory Society as well is aware of this and involved. The American Sleep Apnea Association is also aware. And so there's a group of people that are putting a response together, and very likely it'll be a co-signed letter by many of the societies if everybody's happy with the product. That said, while that's very helpful and very powerful to send that to AHRQ, it is equally helpful to have individuals send a response, and even for the Maryland Sleep Society to consider if they want to respond. The responses don't necessarily have to be very long. I think you can really just look at the executive summary and focus on that. The deadline unfortunately happens to be this Friday, April 23rd by 5 p.m. So I'll stop there. John, I don't know if any specific questions people had or you wanted to bring out. Oh,
I'm muted. There we go. Thank you. I appreciate that synopsis. If individuals would like to respond, should they send the responses to HHS, AHRQ, any recommendations?
Yes, so one thing we can do maybe as a society is to share the link for where the responses would be made. At this point in time, because this is a draft, as you pointed out, it's best to submit this online through the AHRQ website. It's a very open web form. You can if you want to read through specific sections, you can then comment within that specific section, or if you just want to make general comments, there's a section for making general comments back. What I would say is that, and I would be cautious, when you read the report, it does raise your blood pressure a little bit. There's no question about it. But, as a field, there are some hard truths that are in there that we also have to acknowledge at this point in time. It's really I think what we really need to do is to sort of say we recognize there are some limitations with where the literature may be at this point, but it's equally an opportunity for us to say that there is a need for answering, continued questions in this space with additional research. But I do think, the sleepiness aspect, it really does not come out. And the more they hear that, they may be likely to make some changes to their report. But, to be perfectly honest, they're probably going to say thank you for these comments, and they will be published. And so that will be part of a historical trail. And that's equally important because later on, it's likely that CMS might come to this. They may decide at the end of the day not to do anything. But if they do choose to come to this, those comments are helpful as part of the historical record because it helps to shape their thought process if they decide to reopen the NCD for the treatment of sleep apnea.
Look, I really appreciate that summary and guidance. If we have anything to share as a society, we'll see about forwarding that to the membership and attendees. If you have any questions, please Google AHRQ technical draft on CPAP. It will take you to the AHRQ link where the document resides. Guys, everybody's been great. Folks, please have a great, safe weekend. Stay well, be well. Thank you for your attendance and have a great weekend. Bye-bye.